to visit Vijayawada and Guntur. I'm an alumnus from Guntur Medical College. Coming back to the topic today, I just changed it a little bit because the crowd here, I understand, is very mixed. We have plenty of surgeons, we have physicians, we have cardiologists, we have a lot of young anesthesiologists and also very senior expert anesthesiologists. Very dear colleagues of mine are here, Nima sir, Suresh, Raju. All of us have been together in ACTA for a very long time. I was expected to talk a little bit on cardiogenic shock. The cardiogenic shock, whenever we talk about cardiogenic shock, as anesthesiologists or cardiac anesthesiologists and coming from very strong backgrounds of cardiac critical care, we do recognize that these patients actually come from different types of settings. Somebody can be coming from a failed PCI, somebody can be coming from a very acute coronary syndrome. So the kind of complex scenarios are in the various stages of the shocks that they present carries a very high mortality rate for these patients if you don't actually attend to them in a right time. Whenever we talk about cardiogenic shock, we actually talk about stratifying them. The commonest stratification that we actually use is the Society for Cardiovascular Angiography and Intervention classifications, which are classified as at risk, beginning, which are the probably two easy parts where we can actually catch these cardiogenic shocks. In that scenarios, you're probably able to rescue them much easierly. Rescuing them is much easier than actually looking at last two classes where is it talking about deteriorating and extremes, because you need a much higher competent setups to actually take care of these patients. The common management of the cardiogenic shocks are actually into four major categories. It is initial hemodynamic stabilization, then use the medical therapy, optimal use of medical therapy like inotropes and vasopressors, and then you actually look at the next stage, which is mechanical circulatory support in terms of the IABP Impella or ECMO, and then of course the root cause, addressing the root cause of the cardiogenic shocks and revascularization options like PCI or CABG. When you talk about the management algorithms of the cardiogenic shock, the common algorithm that is actually used worldwide is what is called the ROSE protocol. The R stands for the recognize or rescue, O for optimization, S for stabilization, and D for exit or de-escalation, E for exit or de-escalation. When you talk about the management algorithm, it's important to understand that you also need to look at the phenotyping classifications of the cardiogenic shock, because you have basically three broad phenotypes in cardiogenic shock. One is a non-congestive cardiogenic shock. Second is the cardiorenal. Third is the cardiometabolic. As you go down on these classes, the risk of the cardiogenic shock increases. Though the mortality rates could also be higher in non-congestive cardiogenic shocks, it is not that they're very safe or the mortalities are better, but in a given setting in non-congestive cardiogenic shocks also mortality could be higher, but definitely mortality is higher in cardiorenal and cardiometabolic shocks. Cardiometabolic definitely very often demands, with multi-organ dysfunction syndrome, very often demands a mechanical circulatory support in that area. One important point to remember when you look at managing cardiogenic shock is the last two phases, which we often actually forget to implement these strategies in the management of the cardiogenic shock. That's why I'm emphasizing on this. It is about stabilization phase and exit phase, or a de-escalation phase. This is a very important aspect to understand. I'll talk about it a little bit later into my talk. The classical management of again, if you look at a little bit more details into the management of hemodynamic management of the cardiogenic shock, it is predominantly classified either into biventricular cardiogenic shock or a univentricular cardiogenic shock or a right ventricular predominant cardiogenic shock. The left side of the algorithm is actually predominantly concentrating on the biventricular cardiogenic shock, whereas the other side of the algorithm is actually on the right ventricular cardiogenic shock, which is slightly different from the management for the biventricular or a left ventricular predominant cardiogenic shocks. I don't want to, it's a very standard protocol, because today my aim of actually talking about these things here is to give you a new concept about managing perioperatively hemodynamic management of the shock. These algorithms are always there in most of your textbooks, most teachings, classically they teach these things. So I do not want to concentrate much on this because of the paucity of the time. What I'm planning to talk today is about a new concept. It is called the protective hemodynamics. Some of the anesthesiologists sitting here, I'm sure all of you would have heard of protective lung strategies. Well, a protective hemodynamics is a new concept that is coming up in management of cardiogenic shock or septic shock, where we talk about a similar line as a protective lung strategy. We'd also talk about protective hemodynamics. So what is this probably protective hemodynamics actually mean? It's basically out of a 5-step approach, which is called a clear approach. We will see what is that each of these 5 steps are basically. And the protective hemodynamics is about do not chase targets which are probably superfluous. That's where you actually push the patient into a harmful status at the end of a few hours, a few days of resuscitations. So this is very important for us to understand, because it's important for all of us to understand that we come from if you look at the old Shoemaker's concepts in terms of resuscitations, they talked about hyper oxygen deliveries to a lot of these patients, which is actually shown in shock trials that it is counterproductive. The first point here is about customize your target. The first C in clear approach, it is customizing your target. So what are your targets? Your blood pressure targets, if vasopressor doses increase, you should actually look at, if you look at your moderating your blood pressure targets. So that you can avoid use of excessive vasopressors. The limits of autoregulation are extremely different. When we talk about autoregulations in body, we talk about a mean arterial pressure targets. Mean arterial pressure targets, we normally typically talk about a target between 60 to 75 mean arterial pressures, but we also need to understand that the different organs has the different autoregulatory limits in our body. So we may have to probably do not look at, ideally looking at always about 75 mean arterial pressure and above. We can also look at in a given patient, if you are able to achieve a good flow between even 50 or 55 mean arterial pressure, and then patient is actually, in all other parameters, the patient is maintaining well, you can limit your vasopressor usage. This is extremely important for us to remember. As I said, accept low arterial blood pressure targets, and it can be advantageous in a number of surgical settings too in the perioperative period. It can probably decrease especially in situations like vascular surgery and neurosurgery, it can actually decreases the reduce of intraoperative bleeding, and thereby preventing you to get into a vicious cycle. Hypotensive resuscitation may offer a survival benefit over conventional resuscitation for patients with hemorrhagic injury, which is an important point. When I talk about it, when I say about a little bit lower blood pressure targets, some of us might think and talk about most of the literature evidences show the higher the mean arterial pressures in resuscitation, the better are the survivals. But let me caution you, if you go back and look at these studies, most of these studies are observational studies, they're not randomized controlled trials. So there are no RCTs that are actually done to prove that these higher mean arterial pressure targets are always the most important thing to actually improve this resuscitation or improve the survival rates. So you also need to look at maintain the intraoperative systolic pressures within the 10% of the preoperative baseline, and you also can actually personalize these targets to the individual patient. One of the theories that are actually coming up strongly is to start measuring the sleep mean arterial pressures the day before the surgery. If you can actually look at it, most of the times the mean arterial pressures are at least 10 to 15% lower than the awake state, and that mean arterial pressures probably could be enough for these patients when you actually start resuscitating these patients, so that you can limit your vasopressor usage. This is what I said, talk about the clear approach. The C is customize your targets. The second one, L, is limit your catecholamines. So minimizing catecholamines is also important for you to understand. So we always classically see, I tend to see there's a lot of norepinephrine usage that has come up into the day-to-day clinical practice than compared to about 10 years ago. This is good thing in a lot of ways, because we do see a lot of vasoplegia perioperatively, and previously we used to actually treat this vasoplegia with plenty of fluid administration, which is extremely detrimental, is probably one of the reasons why we had bad outcomes perioperatively many years ago. So importantly, we need to look at, you had to minimize the catecholamine use. You also look at other multi-receptor targets. Instead of looking at one peripheral alpha constriction, you can think about looking at targeting the nitric oxide pathways for example, in septic shock. If you're handling septic shock, you can combine early norepinephrine in the early periods of septic shock itself with norepinephrine, methylene blue, instead of just depending upon norepinephrine. The other important strong literature evidence that's coming up is in the use of vasopressin. Early use of vasopressin has been shown to actually reduce limit the use of the dosage of the norepinephrine. So we can think about that particular strategy too. And to remember, use the right vasopressor for the right patient at the right time. So any dose of norepinephrine of more than 0.1 microgram per kg per minute should be used cautiously, and then it definitely produces a severe end organ vasoconstriction, especially nephrotoxic. The third part in the clear approach is what is called enhanced flow. One important point whenever you use catecholamines, you need to remember, you need to look at what is called a hemodynamic coherence. Hemodynamic coherence is about disconnect or a connect between the macrocirculatory targets, which we talk about usually when you talk about mean arterial pressure. It is mean arterial as a macrocirculatory target. You should remember that pressure is not flow. What you're trying to do is, when you're resuscitating, you're actually increasing the flow, thereby actually producing more tissue oxygen delivery. The tissue oxygen delivery is a surrogate. The surrogate for the tissue oxygen delivery, what we use is a mean arterial pressure. It's a very bad surrogate in my opinion. So do not actually always, you need to remember this, do not always put a lot of stress on the correlation between the mean arterial pressure. That means if your MAP is great, your circulatory flow, microcirculatory flow is great. No, it's not true. So the hemodynamic coherence is extremely important concept for you to understand. So look at those parameters in your patients when you're actually resuscitating. The microcirculatory targets is also important. Like for example, a simple capillary refill time is a extremely very good indicator for you to look at perioperatively when you're resuscitating these patients in cardiogenic shock scenarios or even in septic shock scenarios or in a systemic inflammatory response. This hemodynamic coherence is what you should keep in mind, because you shouldn't just be happy looking at mean arterial pressure target that you've achieved using your vasopressor. So how to enhance flow? As I said, you have other microcirculatory targets like cerebral oximetry, sublingual microcirculation indices. These are commercially getting available. Cerebral oximetry is already available in all our operating rooms. It's pretty easy to use. And then you can think about using early use of inodilators like levosimendan, dobutamine or milrinone, or even sometimes there is a literature that's coming up. Even dexmedetomidine is actually being used to look at improving microcirculatory flows in these patients. The fourth step is about adjust fluid balance. Let me tell you one important thing. Too much fluid and too less fluid, both are bad. Okay, what happens is when you talk about, for example, in sepsis, in resuscitation, you tend to use in the early part, in salvage part, use the fluid. But that amount of the fluid that you're going to use an appropriate, as what Krishna was also saying, that you look at more importantly, a dynamic hemodynamic indicators, dynamic flow indicators. Excessive fluids can induce loss of hemodynamic coherence, as I was talking to you, due to hemodilution, changes in blood viscosity, edema formation, and oxidative stress. You need to remember this. Extremely important. Excessive fluids are not good in resuscitations. One of the things that's coming up very well in actually preventing excessive fluid administration is what is called a venous access ultrasound. Typically, till now, we actually look at, depending upon assessing the fluid status, in terms of your dynamic fluid indices as a guide to give the fluid, but in terms of assessing the volume status, perioperatively we do an IVC diameter, but that's it became a very basic indicator right now. Apart from that, you also look at venous access ultrasound scores in terms of looking at portal veins, hepatic veins, and intrarenal veins. If you have an IVC diameter of more than 2, and associated with any of these abnormal wave patterns on the hepatic portal or on the intrarenal veins, that means you have a bad score on the venous access ultrasound, and that means you cross the limits of the fluid administration, and it is time to stop fluid administration and start de-escalating your fluid therapy. So the last R is about resolving your underlying condition. It's a very, very important cornerstone in terms of resuscitation, whether you're talking about cardiogenic shock or you're talking about septic shock. It's important. You know, you need to look at, apart from, this is a parallel approach, as you're doing these stages of resuscitations, as I told you, whether it's a ROSE protocol or in a sepsis, the sepsis protocol, we'll just see it in the next slide. Whichever the stage you are in, you should look at parallelly optimize these patients in terms of trying to resolve the underlying condition. If it's a cardiogenic shock, early revascularization is extremely important. If it's sepsis, early identification of the root of the cause for the sepsis, administration of appropriate antibiotics or empirical antibiotic in case if you're waiting for your cultures is extremely important for you to also remember. Early administration of corticosteroids and low-dose corticosteroids is also sometimes indicated because corticosteroid administration does produce sensitization to the vasoconstrictor use, so that you can actually limit your vasoconstrictor use. There is, as Dr. Mahesh was talking about HP axis, it's also important to understand that sometimes these stress patients under the stress and cardiogenic shocks or any of the shock states does have a decrease in the HP axis stimulation, so the sensitivity of the catecholamines is low. So external corticosteroid administrations can increase the sensitivity to the catecholamines. So also other points to remember as you're looking at resolving the underlying condition under the 5-step approach, the last R signifies, look at avoiding low temperature. It is easy to miss this because when you're looking at resuscitating these patients, very often, whether it's an operating room or in intensive care, they do drop temperatures either by the basal conditions or by the ambient temperatures. So, and it's extremely difficult to resuscitate a hypothermic patients. So, it's important for you to remember, unless there's a special condition, it's coming out from a cardiac arrest scenario in a post-cardiogenic shock, sometimes hypothermia does help in these patients. But in otherwise, avoiding low temperatures is extremely important. And also you remember, choose sedation wisely, because what happens is when you use sedations indiscriminately, like for example, if you use propofol to sedate these patients in shock states, it increases the doses of vasopressors. Instead of that, you can start using drugs like dexmedetomidine, as I already said. It also improves the hemodynamic coherence. So wisely choosing the sedations in the critical care or in the perioperative settings does also limit the use of the vasopressors in these settings. Just to give you a little bit of glimpse about what do we do in septic shock, remember again, you can probably look at these protocols of salvage these patients, and you immediately see, depending upon the stages of the septic shock, the patient presents. You can look at a salvage options, but if you already salvage this patient, look at optimization in terms of the hemodynamic targets. The targets are given. But remember, if you're looking at resuscitating a patient with a septic shock, always also pay attention to the diastolic arterial pressure. It's important because we don't look at usually diastolic arterial pressure. You normally go with mean arterial pressures. But your resuscitation targets in sepsis should also focus on the diastolic arterial pressures, apart from looking at early screening or a periodic screening for the echo to look at the LV. If the LV depression is there, early institution or early starting of your inotropes is extremely important for you to be successful in resuscitating septic shock patients. One important word of caution for all of you to remember, whenever you talk about resuscitating shock patients, it's also important for you to de-escalate or reduce or exit therapies into the patient. That means you would have probably in a patient with septic shock, even the surviving sepsis campaign guidelines currently talk about it, lay a lot of emphasis and stress on this aspect. Now, you probably would have given a lot of fluid as a part of early resuscitation in septic shock, but when you're actually moving into a stabilization phase, you should start looking at de-escalation, start taking out the fluid. If the patient is producing urine, probably you need to look at decongesting these patients, because third spacing does produce bad results in outcomes of septic shock. You probably would have received you would have achieved your targets in the first two phases, whether it's in the ROSE protocol or in the SOST, the stabilize, optimize, salvage, optimize, stabilize, and de-escalate strategy of septic shock. You would have achieved in the first two stages. But if you don't pay attention again to the third spacing and edema that happens in these patients and address it in terms of de-escalation, they would probably have a bad outcomes at that particular point of time. So again, I was talking to, just to conclude, the perioperative management or the management of the cardiogenic shock has multiple sites and multiple, depending upon the stages in which these patients present. I just want all of you to remember this particular protective hemodynamics. Do not excessively use vasopressors. Very often, over a period of time, these vasopressors would be enough unless you want to chase. Do not chase these mean arterial pressure targets unnecessarily and produce. Don't go for the overkill. It doesn't really give you great results. Remember protective hemodynamics approach. Remember clear approach. Customize your targets. Limit the use of the vasopressors. Enhance flow. Adjust fluids, and then rescue resolve the underlying condition. These are the important 5 steps that you need to look at whichever the shock strategies, shock resuscitation strategies that you're going to use. I just want to drive home this point of a new concept that you should pay attention to this in terms of the shock resuscitation. Thank you very much.
Thank you, sir.